Chronic kidney disease is common, costly, and often called the silent killer. But chronic kidney disease has not gotten much attention in the quality world until now. I'm Andy Reynolds. Today on Quality Matters, moving chronic kidney disease from the sidelines to the front lines of quality improvement. For background, I called someone who works in kidney care.
My name is Ben Oldfield. I am a primary care doc, and I work in the community health center space. I'm the chief medical officer at Unity Healthcare, which is the largest community health center in Washington, D.C.
Ben, March is Kidney Health Month, and I've been reading a lot about chronic kidney disease, which goes by CKD. 1 in 7 adults in the U.S. has CKD, and that prevalence rises to almost 2 in 5 among Americans who are age 65 and older. That prevalence is astounding to me.
You're absolutely right. CKD is one of several medical conditions for which we really don't have symptoms when we have it. And that's what drives the fact it's prevalent. Many people are at risk, yet many people don't know that they have it. And that means they're not able to address it and prevent it from worsening. Part of why it's so prevalent is the risk factors that make it likely one will develop CKD are themselves prevalent. Things like obesity, high blood pressure, diabetes. So if those things are prevalent, it makes sense that CKD is going to be prevalent. Part of the challenge is that to make an accurate diagnosis requires a blood test and a urine test. In a community health center, it can be hard to get those blood tests and urine tests done.
Why is it hard to get those tests? You've got a pervasive, potentially deadly disease. Blood and urine testing sounds straightforward. What's the problem?
This is one of those things that's complicated for clinicians. If it's complicated for us, gosh, it's got to be really complicated for patients. First of all, CKD is detected on tests that we do in people who have risk factors. That implies someone is already engaged in the healthcare system and keeping up with annual wellness exams, what have you. That's a subset of the population. Not everybody engages in preventive healthcare. We would love it if they did. Then there's this operational challenge of getting that urine test. Oh gosh, did the patient go to the bathroom before coming to clinic? They'll come back, they'll do it again. And then maybe life gets in the way again. These things compound over time. A lot of people may have half the story told. We have the blood test. We think they might have CKD. We need the urine test. It's hard to get them back in the clinic because of structural factors that make getting good healthcare a challenge for many people, that oftentimes we don't fully cross the finish line in making the right diagnosis because of the lack of the right tests.
You mentioned people don't know they have CKD, and you're not kidding. 9 out of 10 people with the disease don't know they have it. Say more about that, please.
A lot of times people don't have symptoms, so they're not worried about anything. It's silent because it doesn't produce a nagging cough, a back pain, something that might clue a patient that, oh gosh, I need to go to the urgent care or the community health center. It also has to do with the fact that people have competing healthcare priorities. When they go to the clinic, let's say priorities 1, 2, and 3 are my sore knee, my erectile dysfunction, and I got a cough, where visits oftentimes are limited to 15, 20 minutes. Addressing those 3 factors that are top of mind for the patient doesn't leave time for education, what we call pre-test counseling. Hey, Mr. Johnson, I'm taking a blood test and a urine test because I want to get a sense of how your kidneys are doing. That's how the conversation should go, but it can be hard to do in today's hurried healthcare. There are additional factors at play here. The kidneys are dynamic organs, and we are dynamic people. How our tests come up on a Monday might be different on a Wednesday. Even things like not having had enough water that day, maybe having had a cold, having taken a lot of ibuprofen for a sore knee. These can alter results of both the urine and the blood test.
Here's something that might contribute to the silence surrounding the silent killer, perhaps. And that is that many clinicians say CKD is hard to talk about. Why?
I do think it's important for healthcare providers to know this is a loaded term. Patients have access to their blood results. Oftentimes before the clinician has seen their results, they may see something that says, oh, this suggests chronic kidney disease, stage 3. Without having had the conversation with a clinician they trust, this can be very scary. I've had many times when patients have already done their Google search and developed fear about what this might mean. They're coming into the conversation in fear and disempowerment, which is the opposite of where I want them to be, which is a feeling of empowerment and knowledge and the ability to manage this. Does this mean end-stage renal disease is at my doorstep? Does this mean dialysis is coming down the pike? Almost always the answer is no, 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 no. If we do X, Y, and Z, we have success at not letting this progress and certainly avoiding end-stage renal disease.
Can you tell us more about why chronic kidney disease is a loaded term and the apprehension people bring to the conversation?
Some folks have learned helplessness associated with chronic kidney disease. The term is tied to people's experience of some scary cases close to them. Oh gosh, I knew somebody who had that. Maybe they have a grandparent or a sibling who had dialysis, and that's immediately where their head's going to go. CKD, that this means downhill, no hope. This might be a death sentence. That's the loaded nature of the term we as clinicians and public health folks need to work against. My goal is to empower the patient so they feel like, yeah, I can manage this and we can do this together.
My impression is that unless they work in kidney care, even healthcare professionals might not realize how pervasive and costly CKD can be. For example, I was stunned to read that fully 1% of the federal budget goes to dialysis. What do you think?
You're absolutely right that once people, if they do get to end-stage renal disease, sometimes referred to as stage 5 chronic kidney disease, this is a major weight on the healthcare system. Its traditional form involves somebody going into a dialysis clinic 3 times a week for several hours to have their blood filtered, doing the work that the kidneys are no longer able to do. And that requires significant machinery, medical staff, nursing. So huge cost on the healthcare system, a huge cost on society and on patients who may have a hard time working or doing other activities in a busy week of dialysis appointments.
Okay, so we've established that CKD can be hard to detect. It's hard to talk about. What do you wish those of us who work in quality measurement would know or do regarding CKD?
Incentivizing us as primary care clinicians to make the diagnosis correctly is critical. As simple as it sounds, to get that blood and urine test and maybe verify it with a follow-up test, it's enormously difficult. And we may need to dedicate resources to help navigate patients through that process. So opportunities to measure how well we are doing as primary care practices at making the correct diagnosis, as simple as it sounds, may be beneficial as we think about measurement. The other thing is thinking about chronic kidney disease as a longitudinal process. It's only half the story to make the diagnosis in a snapshot in time. Where the rubber meets the road and managing this and preventing it from worsening is longitudinal care. What's the follow-up like? How are we doing with the patient over time? Because oftentimes quality measures can look at things in a snapshot in time. Chronic kidney disease really begs us to think more longitudinally.
That's well put. But Ben, I'm confused. You seem to be saying people in primary care need to be incented to get it right? Really?
Yeah, it's a funny thought. We as primary care practices, like Unity Healthcare as an organization, has many quality measures we report as a community health center, but there's not a lot of focus on chronic kidney disease. Yes, there are measures that pertain to diabetes, to high blood pressure, but drawing attention directly on CKD of those patients who are having risk factors, are we pursuing the right testing for them? How often? What are the gaps in care? That's important for people like me at a leadership level, and then can think about, okay, where do I want to dedicate resources? I need to hire, as an example, patient navigators to help close gaps in chronic kidney disease care. Maybe I need a community health worker who communicates well with a certain population. Those are things I think a lot about.
Tell me more about why you think CKD has not been a focus in quality measurement.
Quality measures are focusing us on specific individual topics. Are we doing cancer screenings at the right time? And this is enormously important. Are we doing depression screening at the right time for the right patients? Again, extremely important. But I do think that it directs our attention in certain places. It makes us think about healthcare in discrete ways, like cancer screening, hypertension, diabetes. Are we managing those to the guidelines? And don't get me wrong, if we do that successfully, we're going to do a lot of good and probably prevent some chronic kidney disease. But the fact that a lot of quality measures don't emphasize a holistic look at CKD, it means we're fighting an uphill battle, that clinicians have a really long list of things they need to address. Unfortunately, CKD hasn't risen to the top of that list, partly because that's the way insurance companies and regulatory agencies have prioritized it. The system doesn't necessarily give it the attention that it might deserve.
Does that surprise you?
It does, particularly given the data you shared about not only how prevalent this is, but also how costly this is. For payers, policymakers, and regulatory authorities, we have a large interest in minimizing the progression of CKD to end-stage renal disease. So there's a missed opportunity for us to align and make sure we're dedicating the right resources to prevention. When we're talking about scarce resources, which is our patients' time, our time as clinicians, prioritization is everything. In a normal primary care visit, we can address 2, maybe 3 things. And so we really need to focus on what we're prioritizing. And CKD, I think, unfortunately, doesn't often make it to the top of that list.
Well, CKD is climbing that list. CKD is getting a lot more attention in the quality world, especially as a key piece of a larger puzzle. That larger puzzle is CKM, for cardiovascular kidney metabolic disorder. What are your thoughts on relating CKD and CKM in quality measurement?
There's something exciting about this new conceptualization of cardiovascular kidney metabolic disorder, CKM, because that nicely is lumping things together into one concept. CKM can help us think more holistically about kidney disease as part of a longer spectrum that involves not only CKD, but risk factors and outcomes like obesity, high blood pressure, diabetes, heart disease, risk of stroke. That has a lot of promise for folks on the front lines because that allows us to think holistically and lump what are now totally different filing cabinets in my head into one. That may simplify things and allow us to prioritize better. Instead of diabetes measures, hypertension measures, measures pertaining to obesity, make a composite measure that means we have one cohesive and longitudinal way of thinking about this as a spectrum. That would simplify things. Also, it can help us come together as a multidisciplinary team, because CKM involves cardiologists, nephrologists, epidemiology, diabetologists, folks who specialize in obesity medicine. Those spaces are siloed. This can be an excuse for us to align as a multidisciplinary team. I would encourage listeners to think holistically about that. It's critical that team-based care beyond CKD, but maybe particularly for CKD, needs to be part of the solution.
To learn more, I went to NCQA's point person who's raising the profile of CKD in the quality world and linking CKD to CKM.
Hi, I'm Caroline Blum. I'm Assistant Vice President at NCQA. I'm a geriatrician and palliative care doc, but also have done a lot of primary care. My responsibilities at NCQA involve measures and complex patients and people with multiple chronic conditions. CKM syndrome is really one of NCQA's priorities. The medical community and researchers have known for years that chronic kidney disease is part of a constellation of conditions. If you have obesity, diabetes, hypertension, you're also at risk for, or maybe already have, chronic kidney disease. They all go together, and many people have all of them. We've spent a lot of time thinking about hypertension, a lot of time thinking about cardiovascular disease, and CKD has been the forgotten piece. So it's important to have a focus on CKD now to catch up with the others so that the public knows and the clinicians remember to think about it. We have to bring it up with all of its other risk factors because they contribute to each other.
What impact will that have? In other words, what's the effect that you're working toward?
We think it's going to be helpful to everybody to think about this coordinated risk and the fact that CKD is part of this coordinated cardiovascular kidney metabolic risk. The hypothesis is, as the public and clinicians learn to think about these together, we will sort of pile on, or we'll be able to address them all more effectively because they're all connected. And we won't be in silos. Well, let's fix the heart or let's fix the diabetes. No, they all occur together. Let's fix all the risks.
Caroline, the Trump administration has made chronic conditions a priority. And in January, you convened a roundtable about chronic kidney disease. What can you tell me about that roundtable discussion?
Our convening in January did address 3 goals. We wanted to think about how there might be a framework that would help us understand quality measurement or standards throughout kidney disease. It starts, so you have to have screening, you have to find out when people have it. And as it gets worse, we have to manage it so that people don't get to end stage renal disease. The second part is where in that framework are the quality gaps? And that gets to 3. What steps would close that quality gap? We've made a lot of progress thinking about the frameworks, the quality gaps, and some solutions.
Thanks, Caroline. I know you and others who were part of that kidney disease roundtable in January will produce a related white paper this spring. And we thank our colleagues at Boehringer Ingelheim and Novo Nordisk for their help in that work. Ben, let's give you the last word, and let's end with something different.
I'm looking at a 2013 newsletter put out by Johns Hopkins Medicine, citing you as a proponent of narrative medicine, which is using storytelling to become a better doctor. What is narrative medicine to you, and why did you believe so much in it that Johns Hopkins would write you up about it when you were not too long out of medical school?
What a nice question. As a young doctor in particular, you're trying to make sense of a lot of things. You're facing life and death and challenging emotional situations, seeing people on the worst day of their life, and trying to make sense of it all. And yet you're a novice clinician and a novice human being, learning the ways of the world. To me, literature was a way to understand what was going on, to map things in the hospital onto epic stories, to frankly give me some resolve that this moment is localized in a longer story, but also to connect with my patients. It can be dehumanizing for people to be in the hospital, but narrative medicine, in asking us to think about the stories that the patients their lives are unfolding upon, can be an empowering way to think about, well, I want to connect to you as a human being that can build trust and make life more fun.
Do you have novels or other works of literature that you have found most helpful in your work in medicine?
Wow, these are great questions. And thank you for going in this direction. When I was a college student studying comparative literature, I was particularly interested in the classics. Latin literature, epic poetry, it resonated with me because of how old the stuff was and yet how resonant it can be, that even in this epic tale of war and love, we can find connection with these characters. The life and death, the tragedy, and sometimes comedy lends itself to thinking about how to make sense of the things we see in healthcare, which have all that stuff too. There's funny moments, wonderful moments, and then troubling and tragic moments too.
I think that's a great place to end it. Ben Oldfield, Chief Medical Officer at Unity Healthcare, thank you for being part of Quality Matters.
Thank you.
To learn about data-driven strategies and practical solutions for addressing health disparities in underserved communities, attend NCQA's Health Quality Forum, April 7th and 8th in Baltimore. Topics include virtual care, rural access, health equity, and maternal health. Register at ncqaforum.org. Thank you for listening to Quality Matters. If you enjoyed this episode, please rate this episode 5 stars. We'll see you next time.